Um, this is injuries and pathologies of the shoulder joint. I'm Jalen Gladney. Introduction of the shoulder joint. The shoulder joint or glenohumeral joint is a multi-axial joint in the human body that allows for movement in all planes. It is formed by the humerus and the scapula through the attachments of muscles and ligaments. It serves as the most movable part in the body. Due to its anatomical position, lack of strength, and laxity of ligaments supporting it, the shoulder experiences frequent injuries. Most common injuries occur to the rotator cuff, such as rotator cuff disease and frozen shoulder. It is imperative, especially for athletes who compete in overhead sports such as baseball, swimming, and tennis, to maintain shoulder health and stability or risk the cost of decreased mobility and performance. Anatomy of the shoulder joint. The shoulder is made up of three bones, in which are the scapula, clavicle, and the humerus. A acromioclavicular joint in conjunction with the glenohumeral joint allow the shoulder its movement. The glenohumeral joint is formed by the ball end of the humerus and the socket-shaped edge of the scapula. The sternoclavicular joint acts as a saddle, as is the only joint that connects the humerus to the axial skeleton. The scapulothoracic joint is not necessarily a true joint, but is more so a articulation of the scapula in which layers the posterior thoracic cage. The humeral head articulates with glenoid fossa, as the fossa is responsible for only a quarter of supporting the humeral head. The first image displays the right glenohumeral joint anterior view, in which we can see the glenoid fossa. The second displays the right humerus, the anterior view and posterior view. And the third image displays the right glenohumeral ligaments in its anterior view. Axial movement and range of motion. The chart to the left is a chart of all axial movements. The glenohumeral joint allows the following major movements: abduction, adduction, flexion, extension, external rotation, internal rotation, horizontal abduction, and horizontal abduction.
And my name is Ashton Sentinel. I'll be talking about the rotator cuff disease. Rotator cuff disease involves the muscles and tendons of the supraspinatus. According to the Journal of Bone and Joint Surgery, the supraspinatus has been the most frequent site of rupture. This disease causes dysfunction, discomfort, and pain to the shoulder. When discussing moment arms, data suggests that the rotator cuff contributes between 1/3 to 1/2 of the power of the shoulder. Impingement, a lot of people get confused between impingement and rotator cuff disease. Impingement is AKA swimmer's shoulder. Impingement does not mean that you technically have rotator cuff disease. Impingement is just one of the many factors of rotator cuff disease. Impingement is inflammation of repetitive shoulder activities. Abnormalities are more common with age. According to the Shoulder and Elbow Surgery Journal of Shoulder and Elbow Surgery, prevalence in abnormalities is 9.7% in patients 20 years and younger, and in patients 80 years and older, it is 62%. Along with that, with rotator cuff disease, there are asymptomatic patients and symptomatic, asymptomatic being the majority. Often, rotator cuff disease is a chronic condition, meaning that it happens over a long period of time. The diagnosis and pathology, there's multiple factors of this condition, studies have revealed profuse blood supplies to a portion of the supraspinatus tendon has been an area of hypovascularity, meaning the increased number of blood vessels leading to tendon degeneration. There's a critical zone near the insertion of the supraspinatus. This is where the tears typically occur. Repetitive damage to the supraspinatus occurs when tendons are compressed between the acromion and the humeral head. Asymptomatic cases are high enough for degeneration of the rotator cuff, makes it considered a common aspect of people's lives, making it difficult to distinguish abnormalities. Rotator cuff disease has been accepted as a form of tendinopathy. That includes the clinical features and pathologic characteristics. The cause of this is controversial. Stated by the NCBI, the rotator cuff disease has been appreciated as a form of tendinopathy. This is also known as tendinitis. It's a condition where the tissue that connects muscle to bone becomes inflamed. This leads to a failed healing process, which is typically the end result. Treatment requires rest, medications, physical therapy, steroid injections, possible surgery. Okay.
Okay, my name is Calista Dotson, and I'm going to be talking about frozen shoulder. I'm going to be talking about what it is, what it's caused by, and how to treat it. So first, what is frozen shoulder? It is a condition that causes pain and stiffness in the joints of the shoulder. So basically, a patient cannot rotate their shoulder the way they normally would be able to without it hurting an intense amount. It actually feels like it is stuck. It is very common. Orthopedic surgeons see it often. Just because it's common doesn't mean it's not controversial and does not mean that they know everything about it. But I will get into that more with the pathology and the diagnosis. This causes a decrease in the passive and active range of motion in the glenohumeral joint. The glenohumeral joint is like a ball and socket. So you wouldn't be able to rotate your shoulder clockwise or counterclockwise without a great deal of pain, or even feel like you can't at all. There are 3 different stages to frozen shoulder. The first stage is going to be the freezing stage. This is where a person begins to notice that their shoulder is hurting. They feel like they can't move it as much. It's not as bad as the frozen stage. It just progresses over time. Now, the second stage is frozen. This is when most patients seek treatment. They begin to hurt so bad they can't withstand the pain. They can't move their shoulder at all. So this is where they will begin to get treatment. And then the last stage is the thawing stage. This is where you begin to feel some relief. It is also very gradual. It's not going to happen quickly. So it's the opposite of freezing. So freezing, like I said, is a gradual increase in pain, and then thawing will be a gradual decrease in pain. Now, as I stated earlier, it can be controversial because it is not explained by genetics or a patient's history or their family's history. They're not exactly sure where it comes from, so they're very, it's up in the air, so it's a big disagreement among medical professionals. Now, this does affect 2% to 5% of the general population. Like I said, orthopedic surgeons see it often. So for the diagnosis and pathology, once again, the pathology of frozen shoulder is controversial. That is actually very important because it is still being tested, and they're still running trials and things to see if there is an exact reason that this could be happening. Now, you do not get an x-ray to diagnose frozen shoulder. If you were to do an x-ray, you'll notice a very normal looking glenohumeral joint. It's not going to be inflamed or look torn or anything like that. It's going to look like the average person's would. The way they diagnose you is by running a passive and active test, which means you're going to have restrictions of, like I said, counterclockwise and clockwise rotation of the shoulder. You're going to let the doctor know how bad it's hurting and how far you can go when rotating the shoulder or raising your arm. And that's when they'll decide if they believe it is frozen shoulder or not. Now, the big thing about this is that it actually is associated with other conditions such as diabetes, thyroid diseases, and Parkinson's disease. With the diabetes, this actually can be a first sign of a diabetic. If a person does not know that they have diabetes, but they do end up with frozen shoulder, that might be an alarm for a doctor to check and see if this might be something going on other than just frozen shoulder. Now, with the treatments, this isn't going to be the same for every person. A lot of people are different in how they recover and their recovery time. But most of the time, they're going to start with non-steroidal anti-inflammatory drugs. These first two are actually just attacking pain. They're not trying to increase the range of motion just yet. It's just going to attack the pain, try to slow that down, and make it withstandable to move your shoulder, which also includes the steroid injections, once again, going straight for the pain. And then after those two, they're probably going to recommend or require physical therapy. This is where you do begin to rotate your shoulder, and hopefully the pain is decreased enough to rotate it all the way around, or at least more than you could before. Now, the last resort would be surgery. They don't want to do this as much because it could increase the pain, and it's a longer recovery time. This will all depend on the severity of the symptoms. So if it is way too bad to withstand, they are going to decide on surgery. And if the duration of the symptoms lasts longer than 3 to 6 months, it's going to be a very big suggestion to just go ahead and do surgery. Most people don't last past 7 months, but it does happen sometimes. So this is when they will decide we need to do something about it and do something now. Actually 50% of people say that they still experience symptoms 7 years after they were diagnosed with frozen shoulder, but only 11% of those people said that it affects their daily life. That's the biggest problem with frozen shoulder, is it's going to affect everything you do during the day. You can't reach for things, grab things, even just opening your car door, it's going to affect that. So that's why you need to get treatment as soon as you notice that it is too much to withstand the pain of rotating your shoulder and moving your shoulder around, which would be the frozen stage once again.
All right, hi, I'm Tyler Fleetwood, and I'll just be basically summarizing this shoulder joint up with treatment and management options about the two previously discussed shoulder pathologies, the rotator cuff and frozen shoulder. Calissa just spoke with you a little bit about the treatment options, and there are several different kinds. The most common are either operative or non-operative. And okay, so starting with the rotator cuff, the rotator cuff injuries such as strains or tears are normally caused by overuse or acute injury. And in overhead athletes like volleyball players, basketball players, and tennis players, they are at the most greatest risk for injuring their rotator cuffs because of the constant motion of overhead throwing. So management strategies for a rotator cuff injury include rehab and medication and surgery, and also wearable IMU technology, which I'll talk about here in a second. There's also several newer treatment techniques that I'm going to briefly go over. However, that these new treatment modalities require further research and investigations to determine their effectiveness. And in a study conducted on single professional football team, it was reported that rotator cuff injuries account for nearly half of all shoulder injuries. And in Major League Baseball pitchers with rotator cuff injuries that eventually required surgery eluded a gradual decline in their performance leading up to surgical intervention. So in most cases of rotator cuff injury, management is determined by the type of injury and severity. The rehabilitation program for an athlete with a rotator cuff injury should focus on eliminating rotator cuff and any inflammation, improving shoulder mobility, and addressing stability, strength, and power, and neuromuscular control. So it's important to note that to correct and identify any issues underlying in the shoulder joint during the rehab process. So there are three main phases of rehab when dealing with a rotator cuff injury. In the early rehab, the main goal is to reduce pain and inflammation and swelling and restore the shoulder joint back to your normal range of motion. So common modalities such as ice and electrical stimulation and manual therapy are commonly used techniques during this stage. The quicker or less time it takes an athlete to heal, the sooner that the athlete will be able to start a progressive strengthening program. So it's important for the athlete to avoid activities that can irritate the shoulder during this time, such as weight training and sport-specific activities. Joint mobilization and passive range of motion techniques assist in restoring normal joint kinematics and improving glenohumeral joint range of motion. So a commonly used and safe shoulder exercise to reduce joint stiffness and improve range of motion is called the Codman's pendulum exercise. And there's a picture of that on the right hand, the drawing. And it's just basically a passive exercise that uses the weight and the momentum of the arm to encourage movement at the shoulder joint while maintaining the inactivity of the injured muscles. So once improvement is reached, range of motion exercises can be progressed to active assisted activities followed by active unassisted activities, such as the images on the right. Exercises like the modified sleeper stretch and the modified crossbody stretch help to increase range of motion in the glenohumeral joint. And another solid method that's commonly used during early rehab is aquatic therapy. The properties that make up the water act as a natural resistance to the body. So along with aquatic therapy, there's isometric exercises and isometric exercises are safe and effective treatments in the early rehab process as well. They help in promoting muscle activation and lead to more advanced isotonic exercises. The goal in the intermediate phase of rehab is to include progressive strength programs focusing on the scapular musculature and the rotator cuff. So the scapulothoracic joint plays a critical role in the overall function of the shoulder, and the scapula provides a stable base that allows the humeral head to elevate and rotate during functional activities. So because sports-related movements occur in many joints and multiple planes simultaneously, the scapulothoracic articulation plays a pretty important role as a bridge between the musculature and lower extremities as kinetic energy is transferred up the chain during sport-specific movements such as football or volleyball. A progressive scapular strengthening program should be included in the middle stage of rehab, and exercise an example of a progressive strengthening exercise would be the clock exercise, the wall clock exercise, and also the foam roller exercise, which is pictured here to the right. So closed kinetic chain exercises are believed to promote a greater co-contraction between the rotator cuff and scapular stabilizers to stimulate joint mechanoreceptors and better replicate certain sport demands. So there's been studies using electromyographic analysis of the rotator cuff muscles, and the studies have shown that sideline external rotation produces high EMG activity in the infraspinatus and teres major muscles. So a newly emerging technique is called the blood flow restriction training, and it requires an inflatable cuff to be placed around the shoulder limb, creating brief periods of venous blockage while the athlete performs exercises at 20 to 40% of 1 rep max. Blood flow restriction has shown to provide hypertrophy and strength similar to traditional resistance training programs. However, it's a new technique and there's not enough research out there to decide whether it's effective treatment or not for rotator cuff injuries. And the final stage in rehab is the advanced phase, and it normally includes advanced strengthening, endurance training, dynamic stabilization, and sport-specific activities to get the person back on to whatever sport it is they were playing, or whatever job they were doing that required heavy use of the shoulder joint. So going on to the next method, medical treatment is another common form for rotator cuff injuries. And there's a lot of medications out there that can be used. There are NSAIDs, which are non-steroidal anti-inflammatory medications. Those are the most commonly used for short-term treatment for injury that brings about pain and inflammation in the shoulder. So NSAIDs pose health risks when used long-term, and this includes side effects as gastrointestinal illness and elevated cardiovascular risk. Corticosteroid injections are also commonly used in orthopedics and share similar benefits to NSAIDs. Caution must be used with those as well, because repeated injections can increase the risk of tendon weakening and rupture. So some less commonly used medications include prolotherapy and platelet-rich plasma injections. So when non-operative management of the rotator cuff injuries is not effective, surgery is the next form of intervention. And there are several different ways to operate treatment on the rotator cuff, but limited evidence supports one method over the other. But the most favored form of surgery is the arthroscopic technique, since it avoids many complications when compared to open surgery. So one future treatment option gaining interest is biological augmentation for degenerative tendopathy, which current options include PRP, platelet-rich plasma therapy, and cell-based therapy. But because of FDA regulations currently, there is limited data, and further research is still needed to determine if those effectively improve tendon healing. So moving on to frozen shoulder injury management, inertial measurement units, or IMUs, that are a type of wearable-based sensor system intended for kinematics, data extraction, and analysis. Basically, IMUs work by using sensors to measure body segment and orientation by integrating acceleration and angular velocity signals, and they can be synced with a smartphone through an app. And the benefit to these IMUs is that they don't have limitations like traditional mechanical measurement, manual measurement tools, and they give detailed and valid measurements of different movements. So several exercises to improve shoulder pain and range of motion are the supine flexion and the standing extension, where a person stands and holds a bar horizontally behind the body with arms about shoulder width apart, and then hands positioned so the knuckles face the ground. And you just start the lift by moving the arms in an upward movement until the stretch is felt. And you do this for about 15 to 20 seconds, 10 times a day. Okay, so each of these exercises should be repeated 10 times a day, each day, for maximum benefits. And it's important to remember, if pain is ever experienced during any kind of stretching exercises, the person should immediately stop the stretch and seek out medical advice from a professional. And physical therapy is also a very effective form and common form of treatment, regardless of the stage of the injury. And non-steroidal anti-inflammatory drugs are also a good way to treat pain symptoms associated with a frozen shoulder, but these drugs shouldn't be used frequently. They're more for short-term injury management and pain management, and they also don't improve range of motion and have multiple side effects. So basically, when it comes to any sport-related injury, decisions on return to play following an injury, such as a frozen shoulder or rotator cuff tear, should be made collectively with a team physician and rehab staff and the athlete. The athlete should, before returning to play, should be able to demonstrate adequate power and muscular endurance consistent with pre-injury levels. And the return to team-related activities and training should be carefully planned and adjusted accordingly based on the athlete's recovery and performance. This gives the sports medicine staff the best chances to return the athlete to his or her competition.